Hello, I'm David Cutler, Dean of Social Sciences in the Faculty of Arts and Sciences at Harvard. Thanks for joining us for this second installment of our From the Studio series. Here we engage our world-class experts on topics of critical importance to the nation and world. I can't think of anything more pressing than the global mental health crisis we're living through, with rates of suicide up 35% in the United States over the past 2 decades. There are sharp increases over the same period in rates of anxiety and depression, with the trend lines particularly alarming when it comes to youth. Today's panel features 4 of the university's top authorities on mental health, depression, anxiety, and trauma. The depth and breadth of the expertise they offer is unique to Harvard. The panel will speak on whether the U.S. is experiencing a loneliness epidemic and mental health crisis. They'll wrestle with the impact of new technologies and discuss how they're harnessing the power of smartphones and chatbots to improve, rather than harm, mental health. We put out the call for viewers to submit questions in advance of today's event. If you missed the window today, keep an eye out for future installments in this series when you'll have more chances to pose questions to our faculty experts. I'd now like to introduce our exceptional moderator, Al Powell. Al is senior science writer for the Harvard Gazette. In his time at Harvard, he's written about topics as diverse as AI in medicine, loneliness and depression, and the science of love. Al has also taught journalism for more than 10 years at the Harvard Extension School. Al, the floor is yours.
In 2021, the U.S. Surgeon General called attention to declining mental health among America's youth, citing a 2019 study showing 1 in 3 high school students and half of female students had persistent feelings of sadness or hopelessness, a 40% increase from 10 years earlier. In 2023, the Surgeon General called attention to an epidemic of loneliness and isolation among Americans of all ages and backgrounds, with some telling him on a listening tour, "If I disappear tomorrow, no one will even notice." Other warnings aren't hard to find. The World Health Organization in September said that more than 1 billion people worldwide are living with mental health conditions. A Gallup poll in March found that the pandemic-era decline in U.S. mental health has lingered in the years since, and another in September found that the percentage of U.S. adults who currently have or are being treated for depression was at the highest level since initial measurements in 2015, a level that's been stagnant for 2 years. Several things have gotten the blame. The COVID-19 pandemic severed connections between people and fostered an environment of fear, uncertainty, and isolation. But the trends that the pandemic exacerbated predate it and may have roots and shifts in how we live, work, and interact. Technology's impact on our lives has become an inescapable part of any mental health discussion. It's put information at our fingertips, enabling greater connection over large distances, even as it pulls us away from the here and now. A new generation of artificial intelligence seems destined to change how we learn and work, even as we struggle to adapt to past changes. Technology helps as well. Our phones keep us mindful and help us meditate, and our watches monitor our bodies in ways that not long ago required a visit to the doctor's office. Welcome to From the Studio, a symposium series from FAS. Today we'll explore our fraught and rapidly changing mental health environment. Our accomplished panelists have deep insights into how we got here and are exploring new approaches that may lead to badly needed improvements. Elizabeth Lundbeck is a historian of psychiatry, psychology, and psychoanalysis, and chair of the Department of the History of Science at Harvard University. She's the author or editor of 7 books in the field and is currently at work on the forthcoming The Therapist, a short history from Freud to ChatGPT. She recently led a general education course called Psychotherapy in the Modern Self, introducing hundreds of students to the full range of therapeutic modalities, from the analytic to the behavioral, and focuses on the challenges and opportunities posed by the new AI platforms. Lundbeck is also particularly interested in personality disorders, especially narcissism and borderline personality disorder. Kerstin Koenen is a clinical psychologist, epidemiologist, and author. She is a professor of psychiatric epidemiology at the Harvard T.H. Chan School of Public Health and an institute member at the Broad Institute of MIT and Harvard, where she directs the Broad Trauma Initiative. Koenen's research examines why some individuals are resilient, while others develop PTSD and related health problems following trauma, the long-term effects of violence and trauma on mental and physical health, and how to expand access to evidence-based treatments for survivors. Jordan Smaller is a psychiatrist, epidemiologist, and geneticist with a research focus on understanding the genetic and environmental determinants of psychiatric disorders across the lifespan and using big data to advance precision medicine. Smaller is a professor of psychiatry at Harvard Medical School and professor in epidemiology at the Harvard T.H. Chan School of Public Health. At Massachusetts General Hospital, he is the Gerald F. Rosenbaum Endowed Chair in Psychiatry, Director of the Center for Precision Psychiatry, Director of the Psychiatric and Neurodevelopmental Genetics Unit in the Center for Genomic Medicine, and co-director of the Center for Suicide Research and Prevention at Massachusetts General Hospital and Harvard. Matthew Nock is the Edgar Pierce Professor of Psychology at Harvard University and the co-director of the Center for Suicide Research and Prevention at Massachusetts General Hospital and Harvard. He also holds appointments as a professor of epidemiology at the Harvard T.H. Chan School of Public Health and as research scientist at Mass General Hospital and Boston Children's Hospital. His research is aimed at advancing our understanding of why people behave in ways that are harmful to themselves, with an emphasis on suicide and other forms of self-harm. He uses a multidisciplinary approach to better understand how these behaviors develop, how to predict them, and how to prevent their occurrence. In 2011, Nock received a MacArthur Fellowship in recognition of his work. We clearly have a very accomplished panel here, and welcome to you all. Hopefully over the next hour, we're going to have an interesting discussion on one of the nation's major challenges facing it. So when we talk about a mental health crisis in America, what are we really talking about? We hear a lot about anxiety and depression. Is this an anxiety and depression crisis? Is this a loneliness crisis? Or is it across the board to things like bipolar disorder and schizophrenia?
I would really say it's a loneliness, anxiety, and depression crisis. We haven't seen increases in bipolar disorder and schizophrenia. I mean, Jordan's more of an expert on that. Although we've always had a crisis in care of those disorders. There's many people that are suffering from those disorders who don't receive adequate care. And we have a crisis in treatment in that the efficacy of the treatments for those conditions has been problematic in terms of side effects of medications, people being able to get the best treatment. So
yeah, I would agree with that. I think part of the reason we haven't seen a change perhaps in some of these other conditions is they haven't been as well studied as anxiety and depression and loneliness. We've really had a focus on that lately, which is great. But I think we don't really know. Some of the big studies that have been done that sort of document what is the frequency of different conditions, many of the best studies, it's been a while since they've been updated. There's a little bit of positive silver lining kind of news from the latest national survey on drug use and health, which suggests that for some things we're seeing either a plateau or maybe even a decline, things like alcohol use disorders, a little bit of a decline in depression among young people, but mostly it's sort of a plateau at this point, I think.
And I've seen some evidence from American Psychiatric done last May, survey showing that the rates of loneliness have declined. You'll notice that the date of 2021, which was in the middle of the pandemic, was when the loneliness epidemic was named as such. Now, still 1 in 3 Americans feel lonely.
it's still very high.
It's very high, but it's not as high as it was during
Yeah.
the pandemic as we've reinstituted social life.
And I think that nuance is important in the zooming, how are we going to zoom in and out? So a lot of these things, depression, anxiety, suicidal thoughts and behaviors have been increasing in recent years. But if you zoom out, they've been there for a long time, and they've been big problems for a long time. You think about the suicide rate, it's increased in the past 2 decades, but the suicide rate now is virtually identical to what it was 100 years ago.
Oh, wow.
So we see a little ebbing and flowing over time, but when you zoom out, you see it's been a problem for a long time. So a recent epidemic, but more general global problem.
Right. And as well, we've known for a long time, I mean, as long as we've had community studies of mental health, that there's a huge gap between need and treatment. I mean, that we've probably known for 100 years, so that is also not new.
And when you talk about the suicide rate being the same as 100 years ago, has it been steady? So is this kind of a steady thing, or has it gone way
It's gone
up and down?
Yeah, it's increased the past 2 decades. It was coming down the 2 decades before that, and we don't have a good understanding of exactly why we see the ebbs and flows. We also see demographic differences. So the rate in young people has been increasing pretty consistently over time, whereas for older people, it's been coming down. And so a lot of the work that researchers in this area are doing is trying to understand, well, what's leading to these increases and decreases, and can we harness those and help convert those into more prevention and intervention efforts?
That's really interesting.
The downward trend in mental health started before the pandemic, but clearly the pandemic made everything worse. We're several years past the pandemic. How long is this pandemic tail going to be? One of the polls that we talked about in the introduction was the Gallup poll that said we're still kind of feeling the effects of the mental health impacts of the pandemic.
Yeah. Well, as I said before, there's a little bit of a plateauing now, and in some places a little bit of a decline in terms of some of the mental health symptoms. It's easy in some ways to blame the pandemic in a way for a lot of what's been going on. But as we said before, these are trends that have been going on before, and a lot of things that have happened around the time of the pandemic are also, we think, relevant to the nation's mental health. Things like the disconnections, the polarization, the potentially the use of technologies that in some cases may exacerbate disconnection and so on. So those things are not going away. So that concerns, I think, a lot of us.
Things like increase in mass shootings. Other people have documented declines in community participation, whether religious attendance, but participation in community organizations. That also has been declining since about 2010, although I think that's changing a bit now too. So,
now
as a historian, it's really important to take the long view. So the 1919 pandemic appears as if it appears at all in textbooks, is one sentence.
Yeah.
So will we remember the pandemic? How will we remember it in 10 years, 20 years? How will we measure the effects? So we're still in the aftermath.
Yeah.
Right,
So
early.
it's really hard to say,
really early
and I
aftermath.
think that's what everybody's saying.
Yeah.
We just don't know really well.
And there's nuance we should acknowledge in how it affected people differently.
Yes.
Yes.
So we, as many others do, we do work where we monitor people's mental health with smartphones and related technologies. And we started this before the pandemic. And interestingly, we saw during the pandemic, everyone was staying home nearly 24 hours a day. We have GPS trackers with people's consent. And feelings of loneliness skyrocketed. And with that, suicidal thoughts increased. And people who felt more isolated, they thought about suicide more. We saw this in adults, not in adolescents. They seemed to respond, at least initially, not so bad, being home, being out of school, and so on. But that changed over time. Introverts did better earlier in the pandemic than extroverts. So you think about why that might be. People who had more money versus less money. So the pandemic wasn't one big monolith. It affected people in really different ways. And how long that's going to last is still something we're trying to tease.
When we look at that differential of how people are impacted, are you expecting a big divide between adults who sort of had their way of behaving before the pandemic, went through the pandemic, changed their behavior, and came out and went back to that, and kids who, socialization is important in school. Some, especially younger kids, missed a couple of years of school. Is that sort of when we talk about a long tail or a short tail of the pandemic? Is that important in your thinking about mental health? Or are these kids, when we see problems coming among the younger generation, or are they just too young? Too young to be affected, to be measured yet, even.
I think it's a good empirical question. I mean, we see changes in test scores during the pandemic,
Yes.
so we see school performance was affected, and increases in anxiety and depression we see in kids as well. And you think about critical periods, and when kids are learning how to interact and how to socialize with others, learning how to be exposed to alcohol and drugs during adolescence and manage those things in their environment. And now we have a cohort of kids coming through who had a very different experience, and we're still learning how that's playing out as adolescents reach adulthood, younger kids reach the middle school years, and so on. So I think we don't know the answer yet, and we're having a sort of a real-time quasi-experiment.
And I think also social context plays a role. And there's been some interesting studies where they've looked across, where there was a study that did helpline calls globally and found that they were influenced. They went up with lockdown or stay-at-home orders, but they decreased in places that did income support for their communities or their population. And so there are influences, not just local communities. Things were very different. I have family, I live in Massachusetts, but I have family in Georgia. Things were very different in Georgia in terms of what was open, what was closed. And so in addition to saying each individual had their own, I have a friend who says everyone had their own pandemic, but each family, each individual, there was also these macro social forces that shaped people's experience, and places where there was more income support and economic support, there is some evidence that may have buffered some of the mental health effects too.
Yeah,
And
we,
also-
we
yeah,
oh, I'm sorry.
Go ahead. Well, I was going to say the mass death. We
Yes.
have not
Yeah.
memorialized it.
I was-
like 55,000 soldiers died in Vietnam. 1 million Americans died.
Right.
We don't talk about
Exactly.
it. There's
That-
this
I totally agree
unprocessed,
with you.
metabolized
Right.
trauma.
I agree.
Just
That's why I was,
out
as a
there.
I was thinking that. I mean, I was in New York on 9/11, and there's a memorial for 9/11. But I think even myself, I find myself not wanting to read books and see things about the pandemic. I just kind of want to move on. So I also think there's a process, we're past it, but we haven't gotten over it. We haven't really processed the loss.
Yeah.
And you wonder, where's the great book or the great movie about the pandemic? And,
Right.
you know,
I don't,
I don't even know I want to watch it.
I don't. I feel this. I
Yeah,
think
I was-
people just don't want to.
yeah,
it
because
was
you know
so
there's great
tr-
stories there.
Yeah.
but
Right.
We don't
We don't
want
wanna
to
hear about it.
We don't want to hear about it, but we'd rather be angry with each other about
Right.
it. That's yeah.
So whenever mental health comes up, inevitably technology becomes part of the conversation. AI-powered chatbots are the newest kid on the block, and they're powerful tools, clearly, that also provide supportive near-human interactions. Several cases have grabbed headlines, though, of potentially negative impacts of these chatbots, even where they've been accused of encouraging suicide. What's your sense of those cases, and how closely do we need to monitor these chatbots for harmful interactions?
Yeah, I'm curious to hear Liz's take on the history of these things.
We all wanna hear Liz's take.
As I think about new technologies, I think about old technologies, and
Right.
a lot of the conversations that we're having now about chatbots, we had a few years ago about social media. We had a few years before
You
that
had about TV,
TV
probably.
and
Right.
telephones
Right.
and so on, and they're tools. Are these tools good or bad? Well, they can be used like a sharp implement for saving life in surgery or homicide. So
Yes.
I think we're still, for each of them, we've got to figure out how do we use them in a way that maximizes the good and that minimizes the harm. And I think the same arguments and the same approaches are playing out now in social media and large language models. But Liz, this is your
Well,
this
I
is your discipline.
appreciate the nod
Yes,
to
we are.
history. I'll bring up another data point, if you will. The first chatbot for mental health was the ELIZA machine, which was set up by Joseph Weizenbaum, a computer scientist at MIT, and he found immediately that people reacted to the chatbot, to the machine, to the ELIZA, as if it were a person. And there's an apocryphal story of him his secretary was using it in the interface and asked him to leave the room because she was having a private conversation with the chatbot. And even his colleagues who were computer scientists, he complained that they should have known better.
Yeah.
So there's something very alluring about this technology that we don't fully understand yet, all these years later.
Yeah.
Well, we're prepared to attach in many ways, right?
Yes.
So
Yes.
the chatbots are increasingly very good at tapping into some of the machinery that we have ourselves in terms of identifying a connection with something and then
Yeah,
anthropomorphizing it. Yeah.
People talk about it and them hacking our attachment system.
Yes.
Oh, interesting.
And there's been studies, very recent, showing that, well, there's been a lot of focus on the sycophancy, the way that they are primed to agree with us, to mirror us. But a recent study was just reported that the yes answers from ChatGPT outnumbered the yes answers outnumbered the no answers by 10 to 1. So there is something there. On the other hand, people are using them in ways that I think we can't dismiss. We have to be curious about how they're using them.
Yeah.
Right.
I also, though, what are we comparing them to?
Right.
So we three are licensed clinicians. I think to how I learned to do therapy in the room at human to human, I say yes a lot more than I say no.
Yes.
Right.
I do a
Oh,
lot
yeah.
more validating. We're trained, and the evidence suggests there's benefit to validating a person's experience.
Right.
Yes, and I rarely, when I do therapy, say no, you're wrong, and don't do that. So I think we've got to think about what's the right comparison condition.
Right. Exactly.
Well, Freud said the therapist, way back when, Freud said the analyst should be as a mirror to the patient.
Yeah,
And now we complain about chatbots mirroring, but that is part of what therapists do.
Right.
This too is Freud's fault. I also think that we should acknowledge the positive here. So we started talking about the pandemic and the mental health epidemic, or however the long tail is. There's a lot of in the country, in the world, what epidemiologists call unmet need. So there's a lot of people who have mental disorders, struggle with mental disorders, and don't have the access to care.
And that we've known forever. I mean,
We've known
as long
forever.
as
We've known forever.
taken data.
And here comes a technology that not everyone, but a lot more people have access to. And so the possibility, the upside here, I think is really great. It's really incredible.
And it's free.
Right.
And it's free.
And it's free.
So far.
And, so far.
And available at 2 o'clock in the morning.
Right.
You
Always
know, I mean,
available.
Crisis moments, you don't have to wait for an appointment.
Right.
And also, it's moving so quickly that,
Right.
you know, what we're seeing now with chatbots, you know, a couple of years from now will be
Probably even 6 months from now.
right.
It'll
They'll be, you know, much more probably anthropomorphic interactions, and you know, I think there is a lot of possibility for good because. And you can chime in on this perhaps, but you know, we know something about the active ingredients of effective psychotherapy across psychotherapies, right? I mean, there's some core things that that seem to be essential, regardless of the particular kind of school of thought or you know, ideology of a particular therapy, and those are things that you could, you know, if you wanted to, and I think some people are, build into these kind of interactions as sort of supportive, curious interaction, empathy, at least as it's, you know, to some degree, learning new skills and being able to impart that and following up. I mean, there's some basic core things that would be pretty amenable, I think, to this kind of interaction.
And also there's a lot of people doing work on having technology support, for example, rather than like us who had to go to school a million years to become licensed professionals, support community health workers. This is the kind of work we do and other people do in the African context, in Kenya and Uganda. We've for ages people have been training community health workers, people who don't have a college education, to do mental health work, particularly around conditions like anxiety, depression, and now supporting them with technology or using apps. And we've been resistant to doing that in the US for all kinds of reasons, but I think we could learn a lot from that. And also the technology could be used to support people in the healthcare system or in different systems to deliver these effective parts of psychotherapy or support their work.
Are they ready for prime time when we hear about these troublesome cases? It seems that you guys are in agreement that there's great promise here, but are they there yet?
Well, I think
Looking to you.
well, you can talk about suicide, but obviously we need better guardrails, and the companies are talking about that. I mean, there's an illusory relationship. It is a relationship. And for a long time, for almost 100 years, we've known that relationship is the key to effective psychotherapy. So people have said, well, it's not a relationship with a human, but I'm more focused on what's the nature of that relationship people are forming with the chatbot. In what ways does it matter, and what ways doesn't it matter that it's not human? And if you believe, if it's giving you something useful that you didn't have before, who are we to say?
Is that better than nothing?
Right. Is that better than nothing?
Right.
If it's preventing you from seeking help,
Right.
that's a problem. If it's responding to your suicidal ideation with, you know, yay, go girl, that's terrible.
Right.
So you probably have thought about
And
this.
do they know, I mean, do they know, or do you know if people are using these instead of, they're replacing
We don't
other things?
know.
We don't know. Or if it's people who wouldn't reach out at all and they're reaching out to AI. We don't know. Okay. That's,
I mean, there must be some
think,
way
yeah,
in which,
infinite
because the
number of
numbers are, I
variations.
mean,
they're so high.
800 million users a
Right.
week.
So some of the,
yeah.
okay.
Yeah, I see this as in many areas of health and medicine. There's an iteration that has to happen.
Right.
And think about, is it are we ready? Is the treatment ready? There are people dying now. You think about cancer. Is the treatment ready? Well, people are dying today. People are dying yesterday. So let's get the best treatment we can in the hands of people.
Right.
Test it out through the scientific process, see what works, and see if we can make it more and more and more effective. I think the same approach is needed here. We have people who need help now, and a lot of these platforms weren't designed to provide therapy, but people are using them for a sort of pseudo-therapeutic kind of
Right. And now we
relationship.
need to work on that.
So the people are saying, I need help, and I'm going to this technology, these large language models for help, and are getting it. how can we work together to make it more effective
Right.
and iterate over time. So I'd love to see more collaboration between industry and independent scientists to work together to iteratively improve these technologies in ways that improve the health of society.
The scientists at Dartmouth have kind of taken the lead on this, and they've developed a Therabot. So it's a chatbot that has been trained by clinical psychologists and psychiatrists and folks who know what they're doing to provide validated answers. And there was a recent study that showed that it provides clinically meaningful. I don't know if care is the right word, but people, it does pretty good.
But I don't want to lose sight of the
Yep.
the dangers, though, because
Right.
you did start with that, and I think there has to be more attention to regulation and more pressure on the
Who
companies.
does the
to-
regulation, though?
Well, states
Yeah.
or federal. So like Illinois has outlawed apparently chatbots for therapy, but it's kind of a semantic question. What's therapy and what's emotional
Right.
support?
Right.
But there are ways to, if you've been on it for 5 hours, for the bot to say maybe you should, take a break or something like that. So there are ways to build in some guardrails, and we just have to keep pressure on the companies to do that.
And you have situations that there was a piece in the New York Times last week about people who have romantic relationships with chatbots. Some of them are married, and it's in full knowledge, with the full knowledge of their spouses. Is there anything inherently wrong with that, or is that we're talking about?
Well, I read a
human-
lot of the comments on that article, and people are like, no. But as I don't want to be normative here, I think it's an interesting phenomenon, and people brought up, well, men have always been looking at porn. What's wrong with women having fantasy boyfriends? I just want to know more about what's actually going on. People are lonely, and they're finding something here. We don't have to approve of it or disapprove, but it's an interesting problem. I'll just
Right.
take that out.
Would it be preferable if we boosted human? Got people. We weren't bowling alone anymore. To reference a important work in that area. Is that sort of 1960s thinking?
You mean to make people to foster more connection?
Yeah.
Yeah, I think unequivocally. One of the things that we've studied and others as well, looking for what are the factors that are likely to be causally protective against developing things like depression. And over, two things come up. One of them is physical activity, and the second one is social connection. And during the pandemic, we had a study in which people who had good social and emotional support early in the pandemic had half the rate of developing significant depression, and so I think absolutely it's a difficult thing to do. Our society is being structured, I think, in the opposite direction.
Pushing
too much.
us opposite. And you've had studies, I know, where you've looked at people at high risk, genetic risk of depression
Right.
in the military, and found that those in units with high support, high connection in their military units, even though they had high risk of depression genetically, had less new depression later.
That's right.
So
And
even
if
with
they-
high genetic risk, the social support and connection can buffer against that.
That's protective.
Yeah.
Protective. So
So-
I agree with him. But
So with this woman who was profiled,
Yeah.
it was interesting also that she shared her experience with her friends. So it wasn't. It might have been added on to.
It wasn't
It
just
wasn't
alone,
a
it
replacement
was-
for it.
right.
I mean, there was a lot of time she spent alone with the chatbot. Her husband was living in a different country and so on.
Yep.
But she did also, as women tend to do, talked a lot with her friend group about what was going on. So I found that as a kind of interesting subtext.
Interesting. Yeah.
Yeah, I mean, people have different needs and desires.
And when we talk about technology, one technology we're still adapting to, as our heads kind of spinning here with these large language models sort of exploding on the scene, but there's still schools that are talking about whether or not they should have cell phones in the schools, and social media often gets identified as a source of bullying and other harmful impacts on children. Do you guys know of this technology being used for good. There's apps, there's meditation apps, things like that. Are there innovative things going on in that area that you know of?
Absolutely. I mean, I would come back to the idea of these are tools, and they can be used for good and evil. And we actually did a study at Harvard a few years back now where we interviewed teens who were getting psychiatric treatment, and we asked them about their social media use and what is helpful, what is harmful. And we saw pros and cons, perhaps not surprisingly. Everyone said, there are aspects of it that I love. I connect with other people. I see what the new trends are. I learn skills that I can use for my mental health. And on the negative side, I do social comparison, and I feel lonely, and I feel like I don't have enough, and kids bully me, and so on. So kids are using social media. This is the world they're living in, and there's good things happening and bad things happening. So I wouldn't say it's bad, or phones are bad, or televisions are bad, or telephones are bad. There's some good and some bad that can be done. It's more nuanced than that. There's how do we find out how to maximize health and minimize harm?
And we have a study where we're doing an app-based treatment. This is a place we work in Kenya for PTSD, and we're finding. I was a little skeptical. We're finding really positive effects. People's PTSD symptoms are really going down through this with this mainly app-based treatment, and they meet occasionally with a facilitator. So. And that's by people's smartphones, not something we could have done a decade ago. And it's reaching many more people than we could have reached if we were waiting for a therapist trained in the specific evidence-based treatment to see individual patients in their office. So that's also something promising.
Yeah, I think that's really promising. I think there's, social media is not going away. The numbers I've seen are that 75% of young people get mental health information from social media.
That's the other point. Yes.
And there's room for raising the game there. I worry about that a bit because there's so much misinformation and sort of investment in some ways in psychiatric illness as being an important part of people's development, and a lot of expression of people's distress through the labels of psychiatric illness, and often inappropriately. And so it's another thing that I think we have to keep our eye on, because so many people really that's where people are getting their information, and it's not always good.
I couldn't agree more. I mean, it's become a marker of identity.
Yes.
Like through TikTok, there are whole communities around entities that aren't in the DSM, but that have been named by users.
Yes.
And we have to think about other ways for people to express their emotional kind of vulnerabilities and concerns.
Right. It's from a historical perspective, I would think you would know this better than I, but in the 80s and 90s, there were disorders that became very common, multiple personality disorder.
Right.
People began to see their experience through the lens of these things, and they
sharpen and they give you a community, and which are the community is a good thing, but if it's a destructive community,
right, and those diagnoses go up and down as people find new idioms and some ways to express themselves.
Yeah, and there are ways to embed, as Karis was saying, to embed good in them, and to do experimentation. We teamed up with an industry partner who developed an algorithm to find people online on social media platforms who are in distress, and then we experimented with how do we get them to crisis services, and we found that through a little tweak we could boost use of crisis services by about 25%. Worked with another platform to find blog posts that people found really helpful and inspiring, and then randomized people to get those versus not, and found that people who got these blog posts had a significant decrease in their suicidal thinking, and they felt more hopeful, more optimistic, more connected with others. So there are ways to use platforms and new technology in ways that, again, boost people's mental health rather than
we
decline
need
it.
like a Yelp for mental health, where you go on Yelp and you're finding where's the best lunch spot, and it would actually drive you to evidence-based, supported, but that would be accessible and attractive to young people, because often I feel like I have an 18-year-old son, and I just feel like I am so out of date in relation to his relationship to technology, having grown up with it. But if there was a way to drive people to the best mental health services, the best information when they did searches, I'm sure, just like you can maximize the best, a lunch spot or the best coffee place.
So I don't think
you
the
can
kids are using
identify
Yelp though anymore. Right? You can do TikToks.
I know. I don't even. I'm not on any social media, so I'm Yelp. The kids are all like, "What's Yelp?" Yeah, I know.
But we can identify these sites, and we can tell that they're working for the ones who are using them. But how do we get that
Right.
out?
How do we connect
How do
people
we-
with
yeah,
them through
that's
AI
the hard part,
or whatever?
The gap. How do you
Yes.
cross that gap? Is there
Right. How is it weighted in the I don't. That's exactly.
is that something that you reach out to the people who run TikTok to change the algorithm a little bit or something like that?
Well, there's
I think
yeah.
work happen. I mean, the one exciting thing here is that work is happening so much more quickly.
Yes,
Studies are getting done more
exactly.
quickly.
They are.
We're learning more quickly than we did 10 years ago, 20 years ago, when we were going out into the field and giving people paper and pencil surveys to understand how they're doing. Now we can learn how people are doing really quickly and intervene really quickly. The study I mentioned with boosting crisis services, we did that study in 5 weeks on 40,000 people. So it was
Right. So
really
fast.
fast data collection, really fast experimentation.
Right.
Now, Jordan, you're working on something called precision mental health. I know it's just a phrase, and there's lots of work beneath it, but that's intriguing to me. What does that look like?
Well, the idea of precision psychiatry, or precision mental health, is bringing precision medicine approaches. And precision medicine is really the idea that we pay attention to individual variability, individual differences in our genes, behavior, lifestyle, environment, to do better in how we diagnose or treat or prevent disease. So that can include a number of things. And it's a very exciting time because just in the last 10 years, we've seen the advent of some of the things we just talked about, AI, but lots of other scientific advances and scaled data and things, tools in basic neuroscience that we really did not have. And so that opens up a lot of possibility. So the idea of precision psychiatry is often said to be, delivering the right treatment or intervention or strategy to the right person at the right time. Most of the treatments that we have, which are very helpful for many people and sometimes they're life-saving, they don't work for everybody. And they're based on sort of what works for the average person. And none of us is the average person because we're all unique. And so the idea of precision psychiatry is let's understand the variability, the heterogeneity, and try to tailor what's really going to be most helpful to this individual. It also can involve things like discovering new treatment modalities, advances in genetics, an area I'm very interested in, have really been remarkable in the last decade and pointed us to new biology that's relevant to these disorders. That can then in turn generate new targets for treatment development. So I think we're going to see a lot of that. It's an approach that's worked dramatically in certain other areas of medicine, oncology, cardiology, and so on.
Yeah. Lots of promise there, and there's still a lot that's unknown about these conditions at in a biological level.
Indeed.
And Kirsten, you're working on in the Broad Trauma Initiative with trauma and the roots of trauma, right?
Yeah. So what we're working on is we've known for a long time that experiences of trauma, when I mean violence, disasters, serious accidents, are related to not just PTSD and mental health conditions, but chronic disease later in life. My group and other groups have published, for example, on violence, women's experience of stalking related to her development of cardiovascular disease decades later. And so the Broad Trauma Initiative is bringing, Jordan and I we're both affiliated with the Broad, and it's made major advances in genomics and genetic medicine. It's bringing this big science approach to understand how the environment, starting with the adverse environment, gets in our bodies and causes disease. And also trauma is related to so many different diseases. Is there some common biology across them? But also moving towards a more personalized medicine approach, because we know that these experiences of trauma in some people will lead to some of these different diseases, but we don't know how to detect that early, or know what's going to happen with whom. And so it's sort of getting at some of those questions too at a large scale.
And when we think about the future, when we think about where your work is going to lead, and really all of yours, how do you see mental health care changing in 10 years?
Well, I think the big problem with mental health care, probably that dwarfs most others, is access to care. And that's a problem that is multi-determined, a lot of different financial, social, political but also, in terms of mental health specialties, there is a workforce shortage. Some of the things we talked about might help with that. New ways of delivering care, peer-to-peer care, or maybe AI-assisted care. So we have to solve that problem. There are way too many people who are not getting the help that they need, people with serious mental illness. People with serious mental illness, psychotic illness and so on, actually have a shortened lifespan of, 10 to 15 years. I mean, it's staggering, and we don't really, we're not jumping on that, I think, in the way that we need to. So access and quality care is crucial. My hope also is that we're going to advance into this possibility of more precise, personalized treatment that's actually more effective and less easier to tolerate, or reaches people where they are and where they need to be, and I hope a much bigger focus on prevention and early detection, because most of what we do now is reactive. We really need to invest in that.
So can I
Yep,
jump
go
in
ahead.
on
Yeah,
this?
jump in.
For years, it's been the case that about half of the people who seek psychotherapy do not meet the criteria for any diagnosable mental disease. They go for support, for advice, for companionship, for changing oneself, a whole range of reasons.
I
So
mentioned
that
unmet needs. People refer to that as met unneed, where people
Met
go and
unneed.
they
Right.
have access to care, but maybe they don't need it.
Right. So, they're kind of worried well
Yeah.
in some ways. So, from where I sit in therapy communities, there's a lot of worry, will therapists survive this, the new technology? Like, will there be a role for the actual human-to-human
Yeah.
interaction? And I'm a big proponent of things happening when people actually talk to each other. Like, just post-pandemic, we've seen there's an excitement around Harvard now that there wasn't
Yeah.
in the immediate post-pandemic, because we're all talking to each other again. So I just like to keep some focus on that. I agree, access is a huge problem, and therapists are very concerned about that. And there is room for sort of these new technologies really addressing a persistent long-term problem. But I wouldn't want to just completely throw out the sort of having someone in your life that you can talk to problem.
Right.
Yeah. I think keeping human in the loop. Sorry, go ahead.
Oh, no, you go ahead.
I haven't talked to other humans in a while, so I'm not interacting in person. This is
we're all
awkward.
tired.
Used to it.
I think they're different targets. One is we can meet the need that people have who don't have access to care with technology, but we also need to do a better job of seeing people in person. And so
Yes,
figuring out
exactly.
how can humans and technology work together? How can technology help us do our job better?
Right.
Thinking about suicide, half of people who die by suicide saw a clinician in the 4 weeks before they died. So they're
We all
getting to
know
care.
stories like that.
They're right, and the risk of suicide death is highest right after people leave a psychiatric hospitalization. So they were in care, they were in round-the-clock care, and then shortly after leaving, they died. So from one of my biggest questions is, and this is a focus of the center that Jordan and I lead at Harvard MGH, is how can we use new technologies to embed into human interactions to provide better round-the-clock care, reach people when they need it, not in the absence of humans, but in addition to their human connections.
So using AI to augment, not to replace.
Yes.
Yeah.
Yes.
And I think the other piece that we need to think about is the brain doesn't exist separate from the rest of the body. And as Jordan mentioned, there actually is really good evidence that exercise can prevent depression. And I think that it's pretty causal evidence. And even in the area I work in, which is post-traumatic stress disorder, I was very skeptical of this. I do yoga, I do meditation, I do all that stuff, but there's recently been large clinical trials where they've compared a cognitive behavioral therapy that's the gold standard for people with PTSD against trauma-informed yoga, randomized. They had the similar effects on PTSD symptoms, and there was less dropout from the yoga. I would have said you can't recover from PTSD without talking about your trauma. There was no talk about the trauma in the trauma-informed yoga. So what's going on there, I don't know, but there is this place for other things besides talking. Maybe it was the community of doing yoga in the group. I mean, that can help people with mental health problems, especially anxiety and depression. I don't want to trivialize people with psychotic disorders or suffering from severe mental illness and say that yoga is going to, cure them. But I think there's a lot of exciting developments in the mind and body that we don't really understand that could also, help address this.
So it may be that a future Dr. Chatbot tells you to shut off the chatbot and go for a run, preferably with a whole group of people.
Right.
Yeah, exactly.
Why are you still talking?
With a running club, right?
Very good. So we have some questions from the audience, and or that have been sent in over the last few days from our live audience that we'll get into in the last few minutes of the show. So, like many parents, one listener wrote, "I've recently read NYU psychologist Jonathan Haidt's book, The Anxious Generation, which details how screens are harming young people. I'm curious what the panelists make of the book and its claims. Should parents be limiting screens in our children's lives? What about our teenagers' lives? Should we be pushing our public schools to curb laptop-based curriculum?" Those are about 3 questions. We can merge them
I'll
into
say
one,
one
but
question
yeah, go.
is parents should be limiting screens in their own lives.
Yeah.
So one of the things that I think that doesn't always get said is that and I'm guilty of this as anyone, but our kids watch what we do, and if we're like taking away our kids' phone while we're on our phone, they need to, so I think there's the modeling piece. I know, exactly. There's a modeling piece that I think we could all be helped by reducing screens in our lives. They're attention-grabbing devices. There's studies which show if you have your cell phone in your pocket while you're doing a task, your attention is worse. So I think that we could all benefit from that, like separate from, I'll let others comment on the book.
Interesting.
I was a skeptic for many years, but I am completely convinced. I have some quibbles about some things of the book, but I gave it to my students. They loved it. I now run a class without any devices in the class, and it has changed everything. Everybody's talking to each other. And the students have said, please take away our devices. So I think...
So protect me from myself.
Protect me from myself, because these devices are meant to sort of be addictive, and they are enormous.
They're amazing.
They're amazing devices.
Yeah.
So I worry about the sort of cognitive offloading that's going on when students rely too much. So I would say, yes, get them out of the elementary, junior, and high school classroom. I also worry about the emotional offloading that they're enabling. But I think the cognitive issues of there's been plenty of studies on this. I think they're
these are
serious.
key tools. They're important in all of our lives, and our kids coming up need to understand how to use them, but we need to somehow figure out how not to let them dominate and free them up.
Theme for me is
we
have this from Eliza on, this new incredible, increasingly human-like technologies. We want them in our lives. There's benefit to having them, and people can get access to care and so on, but not that much. So how do we figure out how to integrate with the machines in ways that help us more than harm us? And I think we're still learning. To some extent, we have a natural experiment happening, but it's, I think, on us and our students and our colleagues and folks in industry to figure this out and to test and to experiment and figure out how we do this.
So we have a question on resources. With the lack of resources to assist our community with these challenges, are there actions that people can take to help those around us? If there's a neighbor who's struggling, or
Well, I think in general, being willing to connect with people and checking in with people in your life who you see and may be struggling. Often people don't come out and say, I need help. We see this and Matt can comment on the issue of suicide, where it was often thought that you don't want to ask somebody about their suicidal thinking because maybe that would make them worse. That's not true. And in fact, a lot of the campaigns, both on the public health side, are directed towards having an awkward conversation or asking the question, check in with somebody. And, I think people underestimate how powerful something simple like that can be.
It's the same with, we see that with trauma and violent experiences. People don't want to ask people who've experienced a death or something really difficult because they're afraid it'll trigger them or upset them. But having done this researched for so many years and talked to so many people, pretty much across the board, people are relieved if you ask if you can, if they actually feel like you want to listen to them.
So one of the hard things about being human is embracing the awkward conversations
Right,
exactly.
that we all
Yes.
shy away from,
Yes.
because it could be
Yeah.
helpful ultimately.
You know, a lot of it's true. A lot of psychopathology, alcohol use, substance use, suicide, to a large extent, is about escape. It's about escaping feelings I don't want to have or thoughts I don't want to have. So a lot of the effective interventions teach people to lean in and to experience those. And this goes to reaching out to other people as well. It can be awkward. It can be challenging to reach out and say something or talk about something you think the person doesn't want to talk about. The data suggests you should lean in. You should
And
have
they
those
may not
conversations.
even respond the first time,
Right.
but
That's
maybe that you let them know they'll come back later. So even if you don't get the response and they don't kind of spill it the first time, maybe it still could mean they could still remember that. And I'm sure we all have that, someone who reached out when we were going through a hard time, however we may have reacted.
And everyone else was
Right.
Yeah.
Yeah.
Right. And there are, as people probably know, crisis services or, 24/7 988 when people are in a crisis, or the crisis text line that people can reach out to.
Yes.
And that's important to know. But also this idea of, people are often feeling very isolated, lonely, shamed by what they may be feeling, and that kind of connection goes a long way.
So another question on kind of historical perspective. How much of what we're seeing as a rise in loneliness is a recognition of an issue that's been around for a long time, whereas maybe it didn't used to be talked about, versus an actual increase?
It's a really tough question because we always are assuming everything's a brand new problem and it's
Right.
worse now than it's ever been, and so on. And there are reports of loneliness and writings about loneliness throughout the 20th century. There's a very powerful historical narrative out there that things have gotten worse and worse, and I think part of that informs the sense of an increasing loneliness crisis. There are surveys show 1 in 3 people are very lonely. So we don't have comparable data for earlier. So it's very hard to make a statement. Is it getting much worse? Has it always been? I'm
Are
not
people
sure.
recognizing it more, right?
Right.
Yeah.
There's
But
always been kind of the cat lady, if you will,
Right.
or the widower whose
Right.
wife passed, and he's
Well, what's striking is 1 in 3 means there's a lot of people living with other people who say they're lonely, and I think we can
Right.
mix up living alone and experiencing loneliness, which is another whole interesting, I think, issue.
And also being alone. So the
Right.
well-known psychoanalyst and psychiatrist Donald Winnicott wrote an article about called "The Capacity to Be
Be
Alone."
alone, yeah.
So there is such a thing as being alone as a kind of an achievement of a mature personality. Just because you're alone doesn't mean you're lonely.
Right.
So I often use that in teaching students to kind of make a distinction because there's value in spending time alone.
Yes.
Yes.
It doesn't necessarily mean you're lonely.
Right.
So we have a request for some advice. What principles should guide us in deciding when and how to use technology as part of mental health care? Should it be intentional? I'm feeling blue. I'm feeling depressed. Let's see what chat does.
Yeah, Matt. Well, it was one thing I was saying we hadn't, is also privacy concerns. So that is another thing we hadn't mentioned. So just as a caveat, I don't really have it, just in terms of when we access what happens with your data, if you're putting it out there in terms of your mental health, bringing in other data, accessing your healthcare data via apps. So there is always, that's another piece. I think that's a challenge
So
technologically.
keep that in mind.
Right,
You know,
yeah.
HIPAA,
And on
HIPAA
that
doesn't
note.
apply to ChatGPT, right? Yeah.
No, it's a big issue. Yeah.
My advice is always my advice is to do what I do, which is be guided by science. And there's a lot of apps out there. If we think about, should I use this app or that app? What is the evidence that it works? What is some things that are really well intended? We have found through science don't help, and some things actually harm.
Yes.
And as we iterate, we find out, okay, here are the ones that work. Here are the ones that don't. Here are ways of using technology in ways that are helpful. Here are ways that are harmful or ineffective. So I think just as we iterate, there are ways to figure this out. And I go on PubMed.gov or Google Scholar, and If it's in an area I don't know, which is most areas, someone prescribes a medication for my child. I want to see, has this been tested in randomized controlled trials? There are ways to figure this out using the evidence base that exists.
And if we could make that more accessible to more people, that would be going back to Yelp for mental health.
Do you guys have a sense as to how the news, since I'll throw the news industry in here, how good a job are they doing on this subject? Do you see the coverage? Is it largely factual, or are they off base? Because that is an area where people do get some of their news still.
I've been, impressed. I think, especially more recently. I think people are paying a lot of attention to how do you talk about these things, getting the facts right, and so on.
I think it's on us as well as scientists to do more effective science communication and try and get the word out about what the evidence shows.
Yeah, I have a colleague at the School of Public Health who's been having scientists meet with influencers or creatives, and so that they're providing, who are interested in mental health, so that the material that they provide on TikTok or other platforms is evidence-based. And she's been very successful with that. I think that could be done more. Yeah. She said they come to the School of Public Health, they meet with the faculty, and it's really influenced their content just to make sure that they still have complete creative control, but it makes sure that what they're putting out there has evidence.
That's interesting, because I think the general perception is that sort of folks who are influencers are sort of just shooting from the hip. But clearly,
they really,
some of them really care. They want to get it right.
Yes,
they want to get it right. So mental health policy focuses on treatment. What are new approaches emerging for prevention, especially with depression and anxiety?
So I'm going to put my public health hat on here and say that there are many policies that we don't label as mental health that influence mental health. For example, government financial policies. I have another colleague at the School of Public Health who's looked at parents receiving child support payments and showing that when they receive them, mental health visits didn't increase, but mental health of people in the family improved. So from the financial support payments. So there's just many things. If people are suffering financially, they don't have enough food, there's food insecurity, those things will adversely affect those kids, those families' mental health. So when we think of policy, we have to think beyond. Treatment is so important, but we have to think at a broader perspective.
Right.
Yeah. Yeah, I agree. I mean, again, the things that keep coming up are often either social determinants or things that are lifestyle kinds of changes, which is really nice because in some ways those are very modifiable. And, we have not really taken on prevention as a field as much as we need to. And, just parenthetically, I worry a little bit about what's going on with the whole funding environment and people getting into science to do all this kind of science-based stuff that we know needs to happen, and we know we need a generation of people to take up those kinds of questions. But I think there are some answers that we have now that avoiding substances is a big one as well. People are very worried about the increase in marijuana use. While alcohol has been going down, marijuana has been going up, and there are known psychiatric complications of that. So,
and there's just on the same theme. There's effective prevention programs like suicide prevention programs that have been tested in schools, high schools, middle schools, and shown to be effective. They're not widely used because people fear if we talk about suicide, it will harm kids. 15% of high school students say they've had serious thoughts of suicide in the past year. And we know that asking people about suicide does not harm, and these prevention programs are helpful. But we don't use them by and large, but we do have a lot of training for what to do if there's a school shooter. The chance of a suicidal kid in a school is much higher than a school shooter, so we should be putting those prevention programs out there to help keep kids alive and get through this high-risk period. So again, I think it's on us to do a better job communicating this to the public and implementing the prevention programs we have.
So back to your science, follow the science.
Follow the science.
The big problem is the one that it takes the most lives, or
Yeah.
you know,
And it's open, it's transparent, increasingly science. So I think this is something that we can all engage with in various ways to help try and improve the mental health of our communities
And Jordan's point, to fund the science.
and fund the science. Yeah.
and fund the science. And we'll see how that turns out in the coming weeks and months. So we're just about out of time. I'd like to thank our panelists here for what was a lively discussion. I'd like to invite the listeners to tune in the next time to From the Studio.
Great. Thank you so much.
Thank you.
Thank you.
Yeah.